if I don't remember. Okay, so this is our order. Y'all did a good job telling me what was missing. So if I said morphine, 5 milligrams, IV push, as needed. What am I missing there?
For PRN, you have to know why you're giving the morphine.
So you have to know why, but there's something else.
How much?
No, the time the dose was given.
So time. What specifically with time, Opal? So as needed, is as needed enough, or we need more?
As needed, like Q4 hours or Q8 hours.
Yes. We need as needed is never an appropriate order. So when sometimes when you guys are reading that, you'll see that as a time, you know, because it's telling you to give it as needed, but that is not specific enough. We need to have a time frame. Now, as far as Cheyenne, yes, we are going to want to know a reason. And it will say, you know, IV push, PRN, Q4 hours pain, or Q4 hours fever. So that is going to be your, you're going to look for that. It is not technically always going to be in the order for non-PRN drugs. You know, it's not going to say atenolol, like if we're giving something for blood pressure, it's not going to say atenolol, 50 milligrams, you know, BID for blood pressure. That's your job to know. But if it's an as needed medication, then you do need to know, you know, what we're given that as needed medication for. Does everybody understand the difference between, and we're going to talk about different types of orders as well and what you're looking for. So Abigail asked, do you have to know when the last or first dose was given? So yes, you need to know that, but that will not be included within the order. So I am only specifically talking right now if a physician gives you an order or writes your order on the chart or enters it into the computer, you know, what is that order complete? The order is considered complete if it has these 6 things: the patient, the route, the drug, the time, and the dose. And then your job is the documentation. Now, in regards to administering those medications, Abigail, you definitely need to know the last and first time, or you're not going to be able to safely administer it. Okay. Any questions about those 5 rights? You need to not just know that PD3RT, you need to recognize what's missing, and you need to be able to tell them to me verbally, not just say, yeah, that looks right. If I say, what are the 6 rights of drug administration? I need you to verbally be able to tell me that, okay? Questions before we move on? All right, let's see. What else we got? So, how do we determine if we have the right patient? We need to check their wristband and ask their name and date of birth. You are going to get so sick and tired of asking your patient their name and date of birth, but it is incredibly, incredibly important that you don't skip it, even if you know your patients, you know, just because it's just one of those steps that when you get busy, you just can't skip it. I mean, it's crucial. We need to make sure that it's the right drug. We need to compare the medication. We need to look at the container label, and we need to look at the medication record. So I'm going to tell you guys about some, in a little while, I'm going to get off of this, off of my PowerPoint, and I'm going to tell y'all some real life examples. Medication errors take place every single day. Y'all don't Google. Tell me how many medication errors you think happen yearly in the United States. Don't Google it. I just want to know y'all's thoughts. Type it in the chat. All right, so the highest number I have, let's see. Thank you for the participation. I appreciate it. So I got 150,000, 200,000. Let's see what my most, let's see, they're popping up, so I'm trying to see everything. I don't know how to stop it from giving me notifications. Okay, it looks like the highest number, Mackenzie said 150,000. Sunday said 350,000. You think they're crazy? You think they're way off? What you think? Y'all are all leaning more towards the thousands, it looks like. There are approximately 1.25 million annual medication drug errors. That is solid, y'all. That means that we are dropping the ball and we are missing some of these drug administrations. Y'all think I have made a drug error in my life, yay or nay? Type it in the chat. Think I've made more than one drug error in my life? Yep. 3 offhand. I know of 3 medication errors that I've made offhand, and I am incredibly, I'm a little bit scatterbrained, honestly, but when I'm giving my medications, I am like, don't talk to me. You know, like, hold on a second. I'm focusing, wait, go away. If I'm at the Pyxis, I am at the Pyxis, and I am not having anybody talk to me, and I still make errors, y'all. It happens every single day. So if you don't hear anything else that I say, you are not above or beyond making errors. You're gonna make errors. Unfortunately, I wish none of us did, but we are human and we all will make errors. When you make errors, you have to report them for the safety of your patient, okay? You have to report them. I have never lost a job over a medication error. I've gotten written up for one, but I've never lost my job over it. But the way that so I've been a nurse for what, 13 years, something like that. And so in the big scheme of things, 3 medication errors isn't that critical, but it could have been life or death. You know what I'm saying? It could have been, you know, my fault that one of my patients died. So you never want that to be on you. So make sure you are checking these rights of drug administration, especially your patient, okay? And I'll tell you about some of my drug errors before our call's over so that you guys can just kind of see how they happen in real life, okay? All right. Drug administration considerations. So we need to have, and we kind of talked about all of this yesterday, we need to have factual knowledge of each drug given. We need to have the reasons for use. We need to have general actions. We need to know the common adverse reactions. We need to know special precautions, and we need to know the normal dosage ranges. If a normal dosage range is 0.2 milligrams, let's say that, 0.2 milligrams, and we mistakenly read that as 2 milligrams, we have given our patient 8 times the medication that was ordered. Can y'all see how that could easily take place? So because of things like that, there are some rounding rules and some special considerations. You always lead with a 0. If the medication is less than 1. So if you're giving 0.5 milligrams, you have to put that 0. Y'all see the difference? Because tell me how that could very easily be mistaken for 5 milligrams. Y'all see how that could be a problem? And you never trail with the 0. So we're not going to do 0. We're not going to do 0.50 because sometimes our brain automatically gets rid of that 0 in front of it and we only see 50. So we're not going to trail with zeros, but we are going to lead with zeros if less than 1. We're going to check current and approved references for all drug information. So when we are in the hospital setting, 90% of y'all's medication administration, y'all are going to use electronic, an EHR, which is going to be the electronic where you scan your patient, and we'll talk about more of that whenever when we're in lab, but you'll scan your patient and you'll scan your drug, and that'll be kind of a third check for you almost. And in most of those programs, there's a drop down, where you click the drop down. It's either going to be Lippincott or Davis. There's going to be some kind of program that allows you to do like a spot check on that drug and make sure that why you're giving it. You're going to use those approved references. You're not going to use Google. Google is like my best friend. I love me some Google. But anybody can type anything in Google, right? Anybody can give that information. So unless it's an approved reference, we're not pulling any of that kind of important information off of those rando sites, okay? Like WebMD or any of that. We're checking patients' allergies before administering drugs. We are asking if they've had any adverse reactions previously. We're paying attention to our patients' comments. And then we're going to pay attention afterwards for a change in our patient's condition. So we're not asking about allergies after the fact, right? Like that is a no-go. We're not asking after we've already given them the penicillin. We're asking before we give it. We need to know the guidelines for preparing a drug for administration. So what do you think would be some guidelines that we haven't talked about specific to drugs? Type those in the chat. Y'all think of anything? Like some drugs might need to be ... Yes. Yeah, that's what I was looking for. So some drugs need to be perfect. Whoever said given with food also, those are all good. So we need to take into consideration those that are specific to our drugs. So like insulin needs to stay in the refrigerator. And we're going to learn about what drugs need to do that. But a lot of insulins need to stay in the refrigerator when they're not being used. So if they need to be in a temperature controlled environment, we don't want to carry it around in our pocket for half of the day before we put it back into the refrigerator in the med room. Yes, Zoe, time sensitive. The most, so like blood, for example, when you get your blood from the lab, if you guys administer blood, it has to be given within 4 hours. After 4 hours, it is no longer good. So taking those times and tucking them away in your brain and making sure that you abide by those specifics. Let's see, guidelines for preparing a drug for administration. How do we prepare drugs for administration? Can y'all think? Do y'all know any of that yet? If I'm drawing up a minute, and we're going to learn about this. Okay, yes, perfect. Yes, y'all are headed in the right direction. Yes, beautiful.
When we were in clinicals, like my nurse would open up like the capsules because my patient had a peg tube, and she would open it up and like put it in like the stuff, and then we gave it to her. Well, she gave it to her in the peg tube.
Yes, perfect. So we need to know when we're preparing these drugs, are they okay to crush? So y'all type in the chat. So we're starting with crush. Are they okay to crush? So which drugs can we not crush? Remember I told y'all some stuff yesterday? So we can't crush the capsules, but we can open them. I'm sorry, who was speaking?
You said the ones that, that's going to work the fastest, like the capsules and the gel.
Yes. Okay. So so I was looking for XR. So XR, SR, CR, that's that extended release, controlled release, time release. Those cannot be crushed. Now with our gel capsules, so ideally we would always get a liquid form from the pharmacy, right? Rather than going through all of this, but not all drugs come in liquid form. So if they are regular medications. They can be crushed, okay? Just normal medications. If they are capsules, the capsule itself cannot be crushed, but you can pull it apart and dump it. That is okay for a capsule. And then for gel capsules, Jamika, we can't actually crush those either, but we can poke them with a filtered needle and squeeze them out if there's not a liquid available, okay? So there are ways around these, but we're never crushing extended release, sustained release, controlled release, any of those time release drugs, okay? Very good, very good,
Those
y'all.
gel tablets, could you dissolve those? Like if the patient has like a peg tube?
So not usually. Usually that gel is very thick on the outside, and it won't dissolve in water. So you usually have to like kind of get you a 18 gauge needle and kind of like dig out a little hole and squeeze it. If it's dissolvable, it's not frowned upon. It just doesn't usually dissolve, and peg tubes being clogged up are an issue, you know. So let's see, the next thing that we're going to talk about, y'all said, okay, so we talked about, I got to scroll up. Let's see, temperature, we talked about that, chilled, given with food, we talked about that. We talked about crushing. Okay, mixing, good job, Mackenzie. So especially when we are giving our medications IV, when we move on to that and we're given push medications, some are going to be, you know, per the manufacturer's instructions, some are going to say mix with sterile water, and some are going to say mix with normal saline. Some are going to say mix with, those are the two main things. I can't think of anything else, D5, whatever. But we have to mix them per the manufacturer's recommendations, okay? Let's see, if liquid and powder, you have to shake the bottle, yes. So if it's been sitting in your medication room and we're given, let's say, an antibiotic, and we're given a liquid antibiotic to a child, that sediment is rising, is sinking to the bottom. If we don't shake it well before administration, we're not administering the correct dose of medicine because it's not dispersed equally in that bottle, right? And then enteric coated, yes. So we shouldn't crush enteric coated capsules, Bridget, not because the same reason of the time release, but what is the purpose? Somebody tell me what is different about an enteric coated tablet. Where is it? So the capsule itself doesn't coat the stomach, but you're headed in the right direction, Emily. The enteric coated capsule, that enteric part stops it from being dissolved in the stomach. It's only dissolved once it gets to the small intestine. Yes, Abigail said goes to the intestine. So essentially it protects the stomach. It doesn't necessarily coat it, but it does protect it. So a crushing an enteric coated capsule would not deliver the wrong dosage of the medication to the patient, but it would increase their risk for what?
Would it be like a GI bleed?
Yep, stomach ulcers, GI bleed. Perfect. Yes, it may not be that intense. It could just be irritation and nausea, you know, but essentially, yes. So that is the goal behind enteric coated capsules. Okay. I always talk a lot. Sorry, hold on. All right. So we're checking the healthcare provider's written orders and comparing the label drug with the MAR. And we are washing our hands and not letting our hands touch capsules or tablets. Anytime you're administering meds, you need to have your gloves on, okay? I hate gloves. I wish they didn't exist because I like to touch people and I like to use my fingernails to open stuff, and they're an inconvenience, but they are the greatest means of protecting your patient, okay? Especially if we're giving them something that's going directly in their mouth. So we want to use gloves when we are preparing medications. Everybody's good so far? All right. We are never going to remove a drug from an unlabeled container or a package with an illegible label. When I worked at the LTAC, one thing that I saw nurses do it all the time, and I couldn't do it. When I worked there, LPNs could not administer IV push medications, okay? And so they brought them to the charge nurse. So they would bring me their medications already drawn up, and they would say, can you go give this to Mr. So-and-so? What do you think the right answer to that is? No. Why not? Why? You think people did it? You think charge nurses did it? Every day of their life. But why exactly? Because I didn't draw it up. So that could have been saline, or it could have been morphine. It could have been, not because I didn't trust my LPNs, I trusted them with my life, but I was the person pushing that medication into the patient's vein, and I didn't check any of those rights. So those are always important, and that is how I made one of my drug errors, and I'll tell you all about that soon. So that is frowned upon. Yeah, Robin? Or was it an accident?
That was an accident. I'm sorry. I didn't know
That's
it
okay.
had unmuted.
That's all right. Let's see. So never crush tablets or open capsules or administer a drug prepared by someone else. Do y'all think that a student has ever gotten written up at North Shore for giving a medication that they did not give? I mean, that they did not pull out of the Pyxis?
Yes.
Sure have. Yep. So that's multiple drug errors we've talked about just right here. Return drugs requiring special storage to the storage area immediately after they're prepared for administration. So we talked about that. That's specifically like our insulins and different things like that that need to be refrigerated. Think I've gone home with insulin in my pocket before? Had to bring it back up? Yep. All right. Each time a drug is prepared and administered, follow those 5 rights. Zoe said, ooh, say no. That's right. Just say no. So precautions are taken by the nurse. We're going to confirm questionable orders, verify calculations with another nurse, listen to the patient, and concentrate on only one task at a time. Why do you think the majority of med errors are made? Distraction, and there's one other. Yep, distraction, interruptions. Yep. The biggest things are distraction, interruptions, and also just rushing. Medication administration is not something that you should rush. So your meds need to be given on time, but they do not need to be, you don't need to be rushed to the point that you're giving them wrong, okay? The most common occurrence of errors occur with insulin and heparin, both of which can be life-threatening if given in the wrong amounts. So because of that, what do you think is a way to prevent those drug errors, specifically with those 2 drugs? How can we prevent that? And I want to see some peeps other than the ones who have been typing in my chat, which I appreciate. I just want to see some new names. So how do you think, what can be implemented? It can maybe already be implemented, or you think it would be a good idea to implement? Yep, Cheyenne said having someone double check with you. So when you are giving insulin, you must have a second nurse witness. Okay, that's across the board, every facility I've ever worked at. 2 nurses must check your insulin, 2 nurses need to check your heparin, okay? So the question page said, why is that? Like, why are we checking it? Is that what you mean? Okay, so the reason is very often, you are capable of giving an amount of medication, but you are distracted or you are whatever, that is just one extra way to have somebody, like, it's kind of like proofreading a paper. That's the best thing I can explain. You know, sometimes when you're proofreading a paper, I write a lot of blogs. So whenever I blog, I mean, I'm a pretty educated person, right? And I spell all kinds of crap wrong and forget to capitalize it because my brain automatically forgets to put the, or my brain kind of skips over stuff. So it is just your second, it's almost like your insurance policy. Like I'm saying this is regular insulin, 4 units, and you show it to your coworker and she says, yes, that's regular insulin. Oh no, that looks like 2 units to me. And then you're like, oh crap. Yeah, you're right. Let me put my glasses on. It's just an insurance policy. And then the second thing, Macy asks 2, including yourself or yourself plus 2. Very good question. You and 1 other nurse. And then if there's a discrepancy and y'all just disagree, go grab you somebody else. But the requirement is you plus 1 other person, okay? And I misunderstood Paige's question. She said, how is insulin and heparin the most common occurrence of errors? Very good question. So insulin, when we get into insulin, you will see that there is like a million different types, okay? So there's Humulin N and Humulin R, just as an example, okay? The only difference between those drugs is the letter behind it, right? And the difference is that one of them works within 15 minutes and the other one takes like an hour and a half to work. So if you needed to drop your patient's sugar quickly, we're given rapid, we're given regular insulin, okay? And if we're giving it over a slow, steady pace, then we're given the other one, which you don't need to know that yet. But the idea is the only difference about those is 1 letter, and the way that they work is entirely different. So that's why a lot of errors are made with insulin. The other and then some, like Lantus, you give large volumes. So Lantus is another type of insulin. It's not unusual to give 40 units of Lantus. But if you gave 40 units of regular insulin, you would bottom somebody's sugar out and kill them. Okay, so it's just one of those drugs that doesn't have a lot of leeway. And heparin is the same way. Heparin comes in different concentrations. And so if you give the wrong, so like we flush PICC lines with heparin, but it's very dilute. So if we flushed it with non-diluted heparin by accident, then we could potentially cause our patient to have an internal bleed and die because of the concentrations are so different. Good questions. I appreciate the questions. Otherwise, I just feel like I'm looking at myself. Any other questions? Okay, let's see. All right, medication errors. Be mindful of the time to administer. A physician's order is essential. Look for common orders. So different types of order. There are standing orders. There are single orders. And I didn't elaborate a lot on this on the PowerPoint, but you do need to look in your book and elaborate a little more on this, and we're going to talk about it. So standing, single, PRN, stat, and weekly. So a standing order is an order that may not be in your patient's chart specifically, but it is a known order at your facility. So if a patient's sugar drops below 30, rather than most facilities have orders like this. If your patient sugar drops below 30, we would say that's critical, right? Is that something we have time to call doc about and say, hey, my patient's sugar is 30. She's kind of in and out of consciousness. Nah. Do we have time to hem-haw around that? Nah, we ain't got time for that. So there will be standing orders that say, they're kind of like emergency orders that say, if patient sugar is less than 50, you may administer 1 amp of D50, such and such. You don't need to know that, but that is a standing order, and that is what it's used for. A single order would be something like, my patient's potassium is 2.6. Is that a problem? Yes. So we would be giving a big loading dose of a medicine, but it maybe wouldn't be a continuous order. So it would say potassium 80 milliequivalents times 1 dose now. That's a single order, or it doesn't have to even say now. It can just say times 1 dose. That is given and it's done. It's not an everyday thing, okay? So that's what a single order is. PRN, y'all know, is as needed. Stat means immediately, within 30 minutes, but technically right when you get it. And then once a week. A lot of patches are ordered once a week. A lot of medications for osteoporosis are ordered once a week. So y'all see there's room for error there too, right? If an order is supposed to be a single order and you accidentally interpreted it as an everyday order, it's a problem. If you miss a stat order, that's a problem. If you give a once a week medicine every day, that's a problem. Or if you forget to give a medication that's once a week, every week, that's a problem. So patients can receive the wrong dose, wrong drugs, incorrect dose, drug by the wrong route, drugs given at the incorrect time, all of those things. And the last offense against detecting drug errors is if they occur, you have to tell somebody, okay? You have to. Let's see. So before I'm going to stop presenting for a second. We're going to kind of talk about drug errors, because I do want this to stick out in your brain. I want this to be, I don't want you to be scared to give medicine, okay? But I do want you to understand the gravity of what you're doing. So let me see. Do any of y'all have any, like, make your story short, but any drug errors that have occurred in your family specifically? That have been harmful to someone that you know or love that you want to share? Yeah. Okay, well, let's see. No, most people say no for that. Okay. So my drug errors. The first drug error, I was a new nurse. And I said 3, but I can't remember the third one for the life of me. But I'll tell you about 2 of them. No judgment. This is a no judgment zone, okay? This is just to show y'all that it really happens. And I'm being recorded, so, you know, I guess I'll go to jail. No, my superiors knew and my patients lived. Let's see. Oh, no. Abigail said a family friend got medicine that was wrong instead of staff medication, and it ended up killing him. So that's somebody, we have a pretty small class. I think there's 26 of y'all. So that is someone that knows someone directly that was killed by a drug error. That's pretty, I mean, that's a pretty big deal. I'm sorry to hear that, Abigail. And unfortunately, it doesn't surprise me. Not, you know, just because it happens. So my drug errors, let's see. Oh, let's see. She said it's all good. You make me smile, Abigail. She said, I mean, I'm over it. It was probably my first 6 months of giving medications. I was working at the LTAC, and the way they give medications there, it's a really fast-paced environment. And so what they do is they'll pull all of their patients' medications out of the Pyxis at the same time. I don't know if they still do this, but 13 years ago, this is what they did. And so they get a styrofoam cup and they write their patient's name and room number on it, right? And they pull all of their patients' meds. So they pull for Mr. Jackson and they write Jackson and they put his meds in this cup, right? And then they pull for Mr. Morris and they put his meds in this cup, and da-da-da-da-da. And they keep them in the med room, and then they check them to their MAR, right? So they still did their checks. They checked the first time when they pulled them out check the second time, and they check them at the bedside, right? Well, I was pulling for 2 patients, and I crushed their medication. So if you crush them, I crushed him in the med room. So he had a peg tube. Both of my patients had a peg tube. I crushed his medications. I had pulled them out like I told you, and I crushed them, and I went and gave them to my patient. And I went back into the med room, and I realized that I gave Mr. Morris's crushed meds to Mr. whatever his name, that wasn't their actual name. But I gave the entire wrong medication, and I had checked them. You know what I'm saying? I checked them, and I checked them, and I checked them, but I grabbed the wrong cup. And I went into the patient's room, and I gave those medications. Big deal. Had to go to my supervisor. I cried hysterically. My patient was fine, because at the end of the day, they were both taking blood pressure medications. He wasn't allergic to any of it. But could that have killed my patient? It absolutely could have. It absolutely could have. So that is a way that going fast and pulling more than one patient's medication at a time is very dangerous. You pull for one, you give one. You pull for one, you give one. Okay, don't do all that. Ooh, I'm saving some time. I'm pull all my patients' meds out. Are you still going to see nurses do it? You are, but it is not best practice, y'all. I know from experience, it's not best practice. So that my second drug error, I worked at a surgery center, and we pretty much gave the same meds to everybody, right? Before surgery, we gave Versed to relax them, and we gave fentanyl before surgery. We gave, nausea medication, like general anesthesia, pre-medication to stop them from getting sick, right? And so we did a whole lot of team nursing on that unit. So I would start the IV. It was a real fast unit, way faster than the LTAC, because we were trying to get him into surgery. So, excuse me. So I had started an IV, and the way we had it, the bays are what do you ever call it? It's 1, 2, 3, 4, 5, 6, 7, 8, and they go around like this. And so it's kind of here, give this, blah, blah. So I had my fellow nurse that I was working with. She said, can you go give this to 8? And I was like, yeah, it was a drug we gave all the time. So I gave it to 8, and I checked his armband, and I said, Mr., I don't know their names, obviously, I wouldn't tell you if I did, but I'm like, Mr. Jackson, I got some medicine for you. Okay, give me your name and date of birth. He gave it to me, whatever. So I gave the medication, and about 15 minutes later, put him on the monitor, did everything I was supposed to do. About 15 minutes later, she said, hey, did you give the medicine to 1? Or no, she said, did you give the medicine to 8? And I said, yeah, I gave the medicine to 8. She was like, oh my God, I meant 1. So she told me the wrong patient. But at the end of the day, did I check the order? No, I just did what she asked me to do. I was trying to be a friend, trying to be helpful, gave the medication to the wrong patient. With the patient, so that was no big deal. Anesthesiologist was writing the same order for that patient too, because they were both going to surgery. But what if it wasn't? What if that patient was allergic to that medicine? Can't just take what people say. You have to repeat it back to them. You have to look at the order for yourself, okay? So those are, I can't think of the third one. Maybe I only made 2, or maybe I'll think of it later. So question is, would you go to jail if something like that were to happen, and if it was an accident? So it's kind of one of those iffy things. If you purposefully did it, yes, that would be considered, malice, or whatever y'all learned in fundamentals. What is it? Not malice. What is it? I can't think of the word. Who said it? Somebody said it.
Malpractice.
Yeah. Well, no, it would be malpractice, but it would be, there's another word I'm talking about that I'll look up later. But when you purposefully do it, it's a different thing. Say again, I'm sorry.
Negligence?
Yes. So that would be negligence if you purposefully harmed your patient. Most of the time, you are covered. If it were truly an accident, you're covered under your insurance for the place that you work But I mean, if the family decides to sue and you were in the wrong, you potentially may not go to jail, but you may get a really large suit. You know, stuff like that goes to the court system all the time. I don't personally know any nurses who have been sued or you know, and you can carry like extra insurance and all that stuff. I don't know any nurses who've personally been sued, but I have I've seen nurses have to go to like depositions and say what they did, you know, and say, you know, this is what I did and this is who I reported to and this is how we went forth to correct it and all. But no, of those 1.2 million drug errors, they're not all going to jail. They're not all, you know, getting, you know, some of them are getting slaps on the wrist from this facility. Some of them are getting fired and some of them potentially could go to jail, but it's not like a straight to jail if you screw up kind of thing. Abigail, do you know specifically about what happened? Did the family sue? And then physicians are covered under their malpractice insurance.
They didn't really do anything. They were just kind of mad about it or whatever. And they were just like, well, it happened. We can't bring them back.
Yeah. But it is covered under malpractice insurance and nurses can carry malpractice insurance as well. And doctors have to carry malpractice insurance. Let's see. Mackenzie said her dad, I am so sorry, Mackenzie. Did you, and you do not have to answer this if you don't want to, did you guys sue the facility or the individual who, and if you don't answer, you can just say you plead the fifth. So yeah, so I mean, it definitely happens. I mean, that's based on just this call alone. We know 2 people now who have died of malpractice. So I hope that that's enough for you guys to recognize the gravity of what you're doing. You know, the importance of slowing down and paying attention, and looking for adverse reactions and not talking to people while you're pulling your meds out and all of that stuff. Any other questions about administering medications or making mistakes? Y'all could see where it could happen. I remember being in nursing school and being like, I would never do that. I would never make a mistake like that. That's foolish. That's careless. But it does happen, unfortunately. All right, let me go back to my PowerPoint. Actually, let's take 10 because I need something to drink. I feel like that's a good stopping point. So at 1:05, we will start back, okay? All right, I'm back. So I posted something in the chat. I knew I still wasn't coming up with the right word. It was aggravating me. Negligence is the word I was looking for. Medical negligence happens when a doctor or a nurse causes harm to a patient unknowingly, either through simple ignorance or failing to take action where action is needed. Medication is a common area in which this occurs. So, whereas malpractice, the medical professional is aware of the potential consequence of their actions and they proceed anyway. They move forward knowingly, and their patient is harmed. So one is almost like purposeful and one is accidental. You can still be charged with malpractice in an accident, but there is a little bit of a difference there. Negligence is the word I was looking for. Does that kind of clear anything up for y'all? Okay, so let's see. Let me go back to my PowerPoint.
Miss Trailer.
Yes.
So, do you think it would be like beneficial to me to like read each chapter that we go through like thoroughly?
Okay, so that's a good question. I'm trying to get where I can see you and myself. Hold, please. Because I'm just looking at a weird screen right now. Okay. So the right answer is yes, you need to read every chapter. The answer that I know y'all are not all going to read every single chapter. What I would suggest, I want you to read every chapter. So let me make that clear. I want you to read every chapter. What I would do if I were you before reading the chapter is go to those key points at the end of every chapter and make sure that they look familiar. And we'll go through those together. If you read it and you're like, I don't know anything about that, then you need to read that section 2 or 3 times. You know what I'm saying? Don't just go through the motions of reading it and not absorbing it. You need to hone in on the stuff that you don't understand. Okay. So if you're feeling pretty good, but you need to practice your math, you need to practice your math for 3 hours and skim through that. You see what I'm saying? Like, don't just read the chapter and don't have time for anything else. Okay. You absolutely need to look at the boxes. People skip the boxes, and that's usually where the most important information is found. And you need to look at the nursing alerts as we move forward. Those are going to be in purple, or some books they're purple, some books they're red. Okay.
Okay. Thank you.
You're welcome. Questions? Other questions before we get back on the back on the PowerPoint? Let's see if I can share it again. Do I do test reviews? Not. I am very firmly against looking at the test and saying, you need to know ... I do not do that ever. I will say, I will give you specific medications that I want. Like I'll try to give you like some PDFs, like focus on these. I'll do stuff like I did earlier, like you need to know those 6 rights of drug administration. I'll kind of try to jump up and down on the stuff that is important, but I will not have like a full-blown test review, no. I will do like a Q&A, like if you towards the end, if you want to ask me questions and y'all are struggling, I'll do that kind of stuff, and a review, so to speak, but not like a you need to know this, here's your study guide kind of thing. I don't do that. What else y'all got? Any other questions? You're welcome. Let's see. All right, Marissa, you're the only one I can see, so give me a thumbs up when you can see my PowerPoint. Okay. Okay, so everybody understands that drug errors happen. Far too many happen. We don't want to be a part of it. We don't want to even take the chance. Everybody gets the importance of that. So how are medications administered? You are going to hear me say things like Pyxis and Omnicell. Those are two brand names of computerized dispensing systems. What you do is you go into those systems, you type in your patient, you log in, you have a specialized login that you never ever share with anyone. You log in and you choose your patient's name, and in a perfect world, their entire MAR pulls up on there, and you choose the medications that you want, and then it pops the drawer open. And you look at the medication and you get it out of the drawer and you close the drawer. You don't have to flip through, all of that stuff. So that is how most of you guys will administer medications, through a computerized dispensing system. So if you want to write those two words down so that you always know what I'm talking about, because I'm not going to say computerized dispensing system. I'm going to say Omnicell or Pyxis, because those are the names of the things that they're coming out of. Anybody ever worked or know of any other? Those are the only two drug dispensers I've worked with. Does anybody, have y'all ever seen, heard another name in your workplaces or anything like that? If you have, you could type it in the chat. And then the barcode scanner, if you've been in the hospital. So in addition to pulling these medications out of the computerized dispensing system, there's a barcode specific for that medication that matches your patient. So you scan your patient, you scan it, and it removes it. You have like a little handheld device. And so when you scan them after pulling it out of the computer dispensing system, after you scan the medication, it like removes it from your patient's list. And that is just a way to ensure that you're given the right medications. So does that replace your checking of the medications? Absolutely, positively not. So it has improved medication errors, but on the flip side, it's also made nurses more comfortable and more careless. Can y'all see where that could go both ways? Like, bloop, 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 just scanning and not checking. So it's kind of one of those double-edged swords. It's saved a lot of people, and it's also caused some harm as well. So we'll talk about a drug error that that a nursing student, did I tell y'all this last? I feel like, I guess I've taught farm so many times. I feel like I've told all these stories so many times. Y'all know none of my farm stories, right? From Foundations? Yeah, okay.
Only the one where you root somebody up.
Okay. The one about them given medication in the nursing home? Okay. So for the students who are new to our class, I had a freshman student who we were working in the nursing home, and the nurse in the nursing home gave them a little medication cup with Tylenol and said, "Hey, go give this to Miss Lucy for me." And the student went and gave it to Miss Lucy, because the nurse told her to, and she was intimidated, and she didn't say, "Wait, no, I can't do that. I'm not allowed." She just went and did it. She's lucky she didn't get dismissed from the program. We just wrote her up, and she was suspended for a clinical day. But those are the kind of errors that take place as well. So I was just making sure I didn't tell y'all all this already. So drug dispensing. I was doing clinicals at Hood a couple semesters ago, and some medications are not, it's called not formulary, like they don't have them at the pharmacy where the patient, like the in-house pharmacy at the hospital. So like the doctor will give okay to substitute with this medication, or they will say okay to use the patient's home medication. So if they give the okay to use the patient's home medication, that home medication is sent to the pharmacy. and it's tagged accordingly as if it was the pharmacy's medication. You know, like they put a barcode on it and, you know, do their thing. So when we were giving a patient medications that semester, we were checking, you know, we're doing our 3 checks, and we'll talk a little bit more about the 3 checks in a second, but we were doing those 3 checks, and the medication was in a Ziploc bag. The Ziploc bag had a barcode and a label, and the MAR had a barcode and a label. So we checked the Ziploc bag to the MAR, you know, all of that. But when we got into the patient's room to give the medication, and we took the bottle of medicine out of the Ziploc bag, the bottle did not match the bag. So that is an example of how scanning, it scanned, it went on through, because that Ziploc bag scanned, but the medication that was placed in the Ziploc bag was not the medication that was ordered for the patient. So we caught that error, luckily, and we brought it to the charge nurse. You know how long that patient had been in the hospital? 2 weeks. You know how long they were getting the wrong medication? 2 weeks. 2 weeks. And my nursing student caught the error. So all that to say that barcode scanning does not eliminate errors, okay? Because technically, the nurse was checking, because the outside of the bag did say that, but the medication bottle itself did not. So those are all things to be mindful of. All right. So how are we giving meds? We talked about this yesterday, so I'm going to start moving a little bit faster. And y'all can tell me to move faster. I'll try to go slow so y'all can get a good grasp of it. But if y'all want me to move on, just let me know. So orally, meds given orally, that's the most frequent route of medication administration. We talked about this yesterday. Oral drug forms can be tablets, capsules, or liquids. And we already know specifically about sustained release drugs. And we know that our responsibilities are to verify the drug, identify the patient, assess, make sure that water is readily available, instruct, never leave the patient's bedside to be taken later. Remind me, somebody, my stories are getting long, but remind me about that, about a nursing student being put in a rough situation about leaving a drug at a patient's bedside to be taken later. I'll just tell you now because I'll forget. Patient, we were at clinicals a couple semesters ago, and student nurse went in to give medications. I was with her, and she had a dialysis patient's medications. These specific medications can only be given with food, or they don't work because they bind specifically with the phosphate. It just has to be given with food. Like, it's one of those no exception kind of things. So we went into the patient's room, and he said, "I'm not going to eat my breakfast right now. Just leave them right there on the table." And so she did the right thing, and she said, "No, sir, I can't do that. I can't leave them on the table." And he said, "Says who?" And she says, "Because, that's the rules. I have to administer them. I can't leave them unattended." Did a great job explaining to him. And he got irate, lost his mind, started screaming, "Then I won't take them at all." Like, totally flipped out. And she looked at me like, "What do we do?" I said, "We don't leave the medications at the table. Like, that's just not how we do things." So we brought him to the charge nurse, and the charge nurse said, "Well, that's what they've been doing. They've been leaving him at the bedside for him because that's what he does at home." Yes, but who is responsible? Did that man understand his medications? He was very passionate because technically he was doing the right thing. He was waiting to take it with his food. However, leaving it at the bedside is never the right answer. You can't do that. Even if your patient knows he's actually taken it and he's waiting to do it as directed with food because he kept saying, "My nephrologist said I have to take it with food." We say, "Yes, sir, we understand that. You let us know when you're ready to eat and we'll bring it back to you." And he's like, "That's stupid. That's ridiculous. When I'm ready to eat, I'm going to be ready to eat and you're going to be nowhere to be found," and da-da-da-da. But because the nurses prior had been doing that, it put that nurse, it made her look stupid. And she was correct. She couldn't leave those medications at the bedside. So never feel the pressure to do what other nurses are doing, okay? Even if it's like a cream or whatever. Like, don't feel the pressure to do what other people are doing. Parenteral drug administration or non-oral routes, okay? So that's sub-Q, intramuscular, intravenous, intradermal, intralesional, intraarterial, intracardiac, and intraarticular. Okay, so that's basically everything outside of the oral route. We're always going to wear gloves, use standard precautions, and cleanse the skin prior to giving medications in this way. Okay, if we don't cleanse the skin, then we're providing a portal of entry for bacteria. Any questions about any of those routes? Don't know what they are, never heard of them.
Are we gonna go further into which one these are?
Yes. So we'll definitely go into sub-Q. We'll definitely go into IM. IV will be for IV therapy. We'll definitely talk about intradermal. We won't really talk about intralesional. That's basically when somebody gets stitches, they'll give the medication, the numbing medication directly into the lesion to numb it up. So that's not really something we'll talk about. Intraarterial is into the arteries. We won't give medications that way. That's more in surgery. Intracardiac, same, directly to the heart. We're not doing that. And intraarticular is joint, which we're not going to do that. But we will talk very specifically about all of the other routes.
Okay, thank you.
All right, subcutaneous. When you think subcutaneous, I want you to think fat. Okay. Subcutaneous is the administration of drugs into the tissues between the skin and the muscle. So for all intents and purposes, I want you to think we're giving these in the fat. Subcutaneous injection sites are the upper arms, the upper abdomen, and the upper back. That's what your book says. I've never seen anybody give a sub-Q injection in the upper back. I would, in place of that, add the outer thigh. So those are your fatty areas. And when we're talking arm, we're talking like the fatty part of the arm back here. Not this muscle right here, but this fatty part, which I'll show y'all more in lab, okay? Everybody squeeze the fat on the back of their arm. That's where you would give that. Same with your abdomen. And those outer thighs. So these needles go in at 45 degrees. Unless, okay, so 45 is the right answer. I want everybody to hear me when I say this. 45 is the right answer. If your patient is really thick and they have a lot of sub-Q tissue, we got to get through all that skin. So we're going in at 90. Okay, but the right answer is always 45, unless your patient is a big girl or man. Okay, intramuscular, we are giving directly into the muscle. You need to use a 22 gauge needle or larger. For sub-Q, let me go back to that for a second, and I'll post a PDF before your test. Sub-Q is usually a 25 or a 27 gauge. So remember I told y'all, if y'all can reason, we know the larger the gauge, the smaller the needle, right? So if we're going into the fat, we don't need something quite as strong and as large as if we're going into the muscle. Y'all understand that? So an intramuscular is going to require a little bit larger gauge needle to get through that muscle. Injection sites. you are going to use the deltoid muscle, and I will show you guys how. I want you to know these names and know where they're located in theory. When we're in class, I will show you these locations, okay? And we'll touch them on each other and we'll put stickers on them to where you know where they actually are. But the names of the places you're going to give intramuscular injections are the deltoid, which is in the arm, the ventrogluteal or the dorsogluteal, which is in like the hip buttocks area, and the vastus lateralis, which is the outer muscle of the thigh. Okay, we're going to give those by Z-Track method, which prevents backflow of a drug into the sub-Q tissue. So we're going to move some of that fat out of the way when we're given intramuscular injections, and we're going to pinch that fat up when we're given subcutaneous, okay? Because we want to move the fat if we're giving intramuscular, and we want to go in the fat if we're given sub-Q, okay? And all of that, I need you to know the terms and be familiar with, but we will watch videos, and we will, like I said, we'll look and locate and learn how to find these places when we're actually face-to-face, okay? Oh, let's see. Intradermal is given right underneath the skin, right underneath it, okay? Transdermal is across the skin, like via a patch, okay? So intradermal is directly into that first layer there. We give these, excuse me, when we're doing TB skin test and allergy testing, or when these are used. Okay. We insert the needle at a 15-degree angle, and these are very small needles as well. And it's 9 times out of 10 done on the forearm. I'm sure y'all had to have a TB skin test for school, right? Or some people will call it a PPD. And we want to see a little bleb for these medications. Topical, we are rubbing it directly on the skin. So this says it's not absorbed through the skin. In large amounts, it can be. So there's going to be certain places that we don't apply topical medications in real porous areas of our body, but mostly they are they're absorbed to the site where they are needed rather than systemically. Transdermal, these medications are readily absorbed from the skin. The drug itself is implanted in a small patch-type bandage. This drug system maintains constant blood concentrations and reduces the possibility of toxicity. When we are administering transdermal medications, we must wear gloves. The skin that we put it on needs to be clean, dry, and non-hairy. And we need to make sure that we're taking off the old, excuse me, that we're taking off the old patch before we put on the new one, okay? We usually do this on the chest, the flank, the back, or the upper arm. Paige is asking if we need to know the sizes of the needles. Yes, you need to know a range to where if I had you, go choose a needle, you would know which one to choose. So it's not always going to be like a subcutaneous injection is not always going to be specifically a 27 or specifically a 25, but it's never going to be an 18. You see what I'm saying? So those are, you just need to kind of know a range. And I believe I have a PDF of that I'll post for y'all.
I have a quick question.
Uh-huh.
Okay, so I used to have to give myself the intradermal route shots. I used to have to do 3 every week, but my doctor would tell me to switch arms every week, and like the same with the patches. I would have to switch like sides of the body. Why did I have to do that?
So with intradermal and subcutaneous injections, there's a term it's known as lipodystrophy. This is mainly with the injections. If you inject in the same place over and over and over, it can displace that fat and cause a weird distribution of that and make some, it's kind of like lumpy. It could mess it up. On top of irritation, we want to make sure that, you know, it's more comfortable to alternate and make sure that that area has a chance to heal instead of repeatedly, you know, going back to that same site. And the same is with the transdermal patch, it's mainly skin irritation. You know, you don't want to put it in the same place over and over and over and over. You know what it looks like if you keep a Band-Aid on for, you know, for 3 days, you end up having more skin issues related to the Band-Aid than you do the sore that caused it. I mean, the reason that you're using it. But yes, that's a good point. We always want to rotate sites. And we always want to document the site. So like if we're putting it on the left forearm, we want to make sure that it's on the left forearm. Because if we accidentally put it on the right forearm, when the nurse goes to take it off, you know, like, because you're not always going to be the person who takes the patch. You're not always going to be taking it off if you put it on. So like if you work on a Thursday and that's your last shift, the nurse taking off the patch is coming on Friday. So it's your responsibility to document that you put it on the left forearm so she knows to take it off of the left forearm. So document and rotate, yes. Other questions? Inhalation route. So we're going to sometimes administer drugs through inhalation. They can be given through droplets, vapor, or gas, or through the mucous membranes of the respiratory tract. So we'll sometimes use face mask, which y'all were introduced to in the nebulizer that y'all saw in Foundations when we did our respiratory section. They're going to have metered dose inhalers. They're going to have regular inhalers. Your job as a nurse is to provide proper instructions on how to take those medications, okay? And we'll go over all of that. We're going to give, nurses are allowed to give medications to the eyes, to the ears, and we'll talk about specifically where to administer those medications. So eyes, we're going to go in the lower, I cannot say the word, conjunctiva sac, the lower sac. And we're going to provide our patient with a tissue to dab. We're never going to touch it to the eye, of course. And then with our ears, we're going to give those differently in the, and we'll talk about that more in class as well, in the pediatric population versus the adult population. All right. Monitor, 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 regardless of your medication, how you're giving it, why you're giving it, all of that. It is always your responsibility to monitor their response and document appropriately. That's always, always a priority, is to monitor, assess, and document. That is it for that PowerPoint. What questions do you guys have? Let me get out of this so I can see y'all. And then I'm probably going to, so from the beginning, everybody, we're still pretty good on, everything's pretty straightforward right now, right? Nobody's stressing yet? I didn't see nobody shake their head. Is anybody, let's see who I haven't talked to yet. Let's see. Get ready to get thrown under the bus. Let's see. Angel, I haven't heard you say anything.
I'm fine right now.
You good?
Yes,
Let's see. Bridget, I saw you type in the chat. Candace, you're quiet. You good?
I actually had a question.
What you got?
So, like, all your tests, how are those, like, what do you want us to focus on information-wise for the test? Like, your PowerPoints and...
All of it, baby. I can't even really narrow it down. I can't,
Okay.
because it's a lot. Focus on those key points. Once we start learning meds, focus on meds.
Okay.
Education is always, remember I told you it kind of all is gray area and it kind of all, so I can't say just worry about this. You know, it's
Yeah.
going to be your nursing implications plus your medications plus, so there's not really, the first test is going to be very different. First test is a little more fact oriented. You
Yeah.
know, there's not a whole lot of ways that I can ask some of these questions. So your first test, y'all should do well on. The other ones, it really just, it so depends. It really does.
All the other mainly going to be on all those medications, correct? And like the symptoms.
Medications, education, yeah. Meds, education, assessment of the patients who are getting those meds.
Okay.
Yeah.
Thank you.
You're welcome. Courtney, you there? Let's see. I see something in the chat. Let me see. Hold on one second. I'm trying to get rid of this. To ask about the meds you will give us. I heard you say something about 50 meds and narrowing it down for the test. Yes. So for your meds, once we start getting into medications, I have some. I'll share them with y'all. Hold on. I think I have one. Hold on. It'll look kind of like this. Let me share my screen. Hold on. All right. Paige, you're the only one I see. Can you see need to know medications? All right. So it'll kind of be like this, Macy, where it's not all of the medications, but it kind of narrows it down. Like it picks out the most important ones from the chapter, and I have it broken down for you the best I can. So I won't do that for everything, but I will do that as much as I can for y'all. Just to make it not so overwhelming, because I've learned the longer I've taught this course, the more I've learned that y'all are not going to learn 300 medications. So I'd rather you leave and know 100 really well than know 300 half-heartedly. You know what I'm saying? So that's kind of my goal, and I'm still kind of altering that a little bit. So I'll, as we go through, I will, kind of point you in the right direction. Will you be doing drug cards? What did y'all do at your other? So yes and no, probably not in the traditional way that you did them in your other program. Did they have you write drug cards with the mechanism of action and all of that stuff? Okay, you used them within pharmacology, or you used them within clinicals? I'm gonna let her answer real quick. Let's see. Okay, so you'll definitely use them in clinicals as part of your paperwork. I won't give them to you in the traditional way that you got them there. But when we have class time and downtime, I will have you do some little small projects on the important ones that I feel are important, but it's not the traditional templates like y'all used. But definitely you'll have to do drug cards for clinicals, and Miss Adams or whoever has you will let you know their whatever they want you to do. They'll give you specifics on that. Let's see. Who else have I not heard from? Candace, you there? Type it in the chat. I didn't hear you chat yet. Let's see. Have not heard from Caitlin Mathern, you're quiet. And I think everybody else talked to me. Zoe and Courtney. I don't think I've heard a lot from you guys. Let me know that you're good. Let me know what's up. Because we're about to move on. Let's see. Candace is here and she is good. I like the way y'all added for now. Does that mean you don't think you will be good later? Good for now.
Miss Trailer, what size needles were you saying that you would use for subcutaneous injections?
Subcutaneous vary, usually smaller than a 22. So 23 or smaller, generally speaking. And I will, those can be found, let's see, let me point y'all, let's go to the book for a second before I move on, because I do want to make sure this is the easy stuff, but I still want to make sure that y'all are comfortable with it. Let's see. There's a chart in the book. I just have to find it, so hang tight. Okay. Thank you for letting me know, Caitlin. I'm not seeing the needle sizes on here, but I'll post y'all a PDF for it, for the needle sizes. I do want y'all to look at the box on page 23 in your book. Those are those specifics. Remember I told you we're not going to ever trail zeros, and if we use zeros, we're always going to place a 0 before a whole number, before a not whole number like 0.5 or 0.25. This is some other specifics. I want y'all to pay attention to that chart. Y'all need to know, y'all should already know from Med-Surg, y'all need to know what BID, TID, all of that means, okay? Q4, you need to know what that Q means. You need to know, let's see. Yeah, I'm gonna type them in the chat for y'all. BID, TID. T. Only ones I can think of right now. You need to know what all of those abbreviations mean. Yeah, you can send it, Caitlin. I have it too, but you can send me what you have if you want to. I never turn down resources. Let's see. Okay, here's your sizes. They're on page 26 and 27. For intradermal, a 1 milliliter syringe, 25 to 27 gauge. That is 1/4 to 5/8 inches long. All of this can be found on page 26 and 27. Subcutaneous generally is a volume of 0.5 to 1 milliliter. So we're not given 3 mils subcutaneously, okay? Our tissues cannot handle that. And it's usually a 23 to a 25 gauge needle, 3/8 to 5/8 inch. And you'll have to understand this can vary some, but it's not going to vary extensively. And then IM injections, y'all know those locations. And it's usually a 22-inch needle that's 1.5 inches long. Now, if our patient is very, very, very thin, you think we're going to use a 1.5 inch needle? It's not going to be necessary to get to their muscle, okay? So all of these things, all of the things that we talked about yesterday are important to keep into consideration. There will always be patient-specific considerations for all of these, you know, for all the things that you do for all of your implications. All right, let's see what else we got. All right, I think we're about to move on. Y'all good? Okay, I want y'all to, let me share this. Well, let me find it first. Hold on. All right. Let's see. Marissa, you're the only one I see. Can you see this dosage calculation conversions? Okay. Y'all need to memorize this.
I
Whole
printed
thing.
that off Pinterest. That's really funny.
You did what?
I found that on Pinterest and printed it.
Yep.
I was like, I think I'm going to need this.
Yep, you're going to need it. You need to memorize the whole thing. You need to be able to write it. You need to be able to tell me. Because if you can't write it and tell me, then you're not going to be able to use it. So that everybody heard me. That will be on your first test. You will need to have it memorized. Okay. That is under, it's already on Canvas. It's under the, I don't even know if it's under week 1 or week 2, honestly. But you're responsible for everything in week 1 and week 2. So make sure that you, thank you, it's under week 1, Abigail said. Make sure that you can write that down. I'm trying to decide what I want to do right now. Y'all want to talk about conversions, or you want to move on to chapters 4 and 5? Paige, you are welcome to start your ATI assignments whenever you're ready. They're open. Those are to be done on your own time. Does anybody have questions about, I have pretty straightforward how to get to them. So they're done on your own time. They are, I can see what you did. I can see how much time you spent in there. So the main thing, so the question was, do you have to spend a certain amount of time? Technically, no. However, I can go in and look and see how fast you did it. I was in college. I know how it works. I know y'all have each other's back. And I know if you forgot to do it Sunday, that Cheyenne is going to say, these are the answers, and you can take that test in 5 minutes. I know this. I'm not stupid. I'm not that old. But not going through the modules, and I know I sound teach when I say this, not going through the modules, I think they only take like an hour to go through. Like, I mean, they're not ridiculous. They're not. Not going through them is not going to benefit you. Okay, you'll still get your points. If you turn in your junk, you're going to get your points. But not going through them is not going to benefit you. And at the end of the semester, when you're sucking and you're not passing, and I go back in and I see that you spent 4 minutes on the modules that you were supposed to spend an hour in, who is that on? That's on y'all, okay? And I will be able to say, well, here was the extra stuff that I gave them, and they didn't do it. So technically, Caitlin, no, there's no certain time that you need to spend. Do I want you to go through the modules, even if they're playing in the background while you're taking a shower or whatever, shaving your legs? Yes, I want you to listen to them. Because it hits the high points, and it hits some of the stuff that I don't hit. Because I don't, what do we say, there's 20,000 meds? I can't cover them all. So it kind of fills in the gaps for me. So I would like for you to listen to those. Make sure that you are submitting those PDFs to me to make my life easier. You're attaching them, but I can still go in from my end and see everything that you do. So if you cannot get into ATI, I mean, like you need to let me know.
Will those be uploaded every week on the modules?
Say that again, Paige, I'm sorry.
Will those be uploaded every week under your modules, like of what we need to do?
Yes, yes.
Okay.
And if you look, I think I already have it if you're a work ahead kind of girl. Now, I don't want y'all to work too far ahead because you're going to get overwhelmed. Like as you go on, it's going to be more information. And if you're just a checklist person and you want to get all of your ATI stuff knocked out, I get that. But at the same time, it's not going to be as beneficial because it's not going to be going with the lesson that I'm teaching. You see what I'm saying? And then you're just going to have all of this stuff in your brain. So I don't suggest that. But if you have a lot of downtime, the thing that I uploaded under modules, I'm looking to see what it was called. Let's see. It says Farm Exam Content Outline. Let's see. Let me get it to where y'all can see it. Can y'all see it or no? Can y'all see what I just pulled up? Let's see. Oh, I think it went away. It tells you on there which ATI lessons go with your exams. So they're open if you want to do them, but I wouldn't necessarily suggest that. But I mean, it's up to you. Okay, cool. Let's see what my chat says. So done a couple times already, so we'll still be able to see my current times when I redo them. That I don't know. I think, Macy, because you're in a new cohort, it's going to give me all new information for you. Isabella is asking, we have ATI for your class and Miss Adams or just yours? So my ATI, you should be implementing ATI into every single class that you're taking. Miss Adams is going to have, my ATI is like assignments. Some of y'all's, and I don't know about her class. I haven't asked her or talked to her, but some y'all are also going to be doing clinicals within ATI. There's going to be some certain case studies and all of that stuff. I will tell you, I will caution you. We've had some students in the past who said, oh, I did that for Miss So-and-so's class 2 semesters ago, and they just printed old stuff. And it was not counted for their current clinical hours. So I would be careful in like redoing, reusing all of that stuff. But you should have it for both of our classes. So Macy, after this week, you should not be showing up. You should be showing up as a new student in my cohort. So I'll try to go in. Did you change your, did you go in and change your location and add that product code? Okay, I'll forward you an email. I thought I sent it yesterday, but I'll send you the instructions on doing that, and I'll be able to give you better instructions on what I can see and what I can't. But I'm gonna tell you, you probably need to redo it just to make sure that you're not missing anything and getting all your credit, because it's not gonna hurt y'all. And I may not have sent it to you, Macy. I have a few transfer students, so I'll check when we're done. All right, what else y'all got? We want to do a math lecture, or we want to stick in roaches? What y'all thinking? Let me know what you want to do, because I'm still teaching.
I'd rather do math like when we're on campus.
Okay, I'm fine with that. All right, chapter 4 and 5. It's even. Let's see.
Are we gonna have in-class time, like, to go over the math before we come back to school, like, before the test, I
Okay.
mean?
So my plan, you don't have any real true math on your first test except for those conversions. Okay, so the actual real true math is not going to be on your first exam. I will teach the actual math lesson when you're in class, okay? As far as how to calculate drug dosages and all of that stuff. But you will have conversions. You'll have you'll have kilograms and pounds, and you'll have, teaspoons. You'll have all that simple stuff on there. Okay, let's do chapter 4 and 5. Let me get to it. Let's see. Hold, please. I gotta find it. All right, can y'all see it? Sunday, you're the only one I can see right now. You see the nursing process and patient education? All right, y'all all type the initials for the nursing process in the chat bar. What is the nursing process? I guess y'all don't have to type. There you go. I was gonna say. All right, if you haven't typed it already, you don't have to. So you all are familiar with the nursing process. This is not brand new information. This should be very easy for you guys. All we're doing now is bringing pharmacology into the nursing process, okay? So that's what we're going to be doing today. So assessment, diagnosis, planning, implementation, and evaluation. Y'all know that already. Okay, so this is where I am going to probably call y'all's names, and it's really not to throw y'all under the bus. It's just to make sure that everybody is with me and paying attention. So I have y'all's roster here. Of course I don't, it's on my other phone. Got 2 phones. So real fun fact, real quick. All my stuff won't transfer, so my text messages come to one phone. My calls are coming to the other phone, and I can't keep up with one phone, more or less 2 phones, so it's a whole crisis in my household currently to try to get these 2 phones synced. But anyways, okay, so I'm just going to call y'all's names. Tell me, or you can type it, I don't care, objective data that might be used when administering medications. Y'all remember objective versus subjective? Y'all remember what that means or no? If you don't remember what that means, it's okay, I'll go into it. But y'all got to talk to me. Okay, so we are okay. Okay, so repeat the question.
Objective data going into administering medication, would that be a blood pressure?
Yes. So objective is measurable, right? So a blood pressure is measurable. We need to know. Okay, so refresher. I'm glad. I would rather y'all tell me repeat refresher. So let me reverse. So objective is our assessment data that is measurable. There's a way for us to measure it, okay? Subjective is more going to be the things that aren't necessarily measurable. It's the things that our patients tell us. Does one matter more than the other? Yay or nay? Or give me a thumbs up, thumbs down. Is subjective more important than objective? Or vice versa? No, they go together. They go together. Because if our patient is saying that they have, that they're saying that they feel incredibly dizzy, like, oh, I'm so dizzy, but their pressure is normal, does it mean they're not dizzy? You don't have to have low blood pressure to be dizzy, but we need to know those things. So objective data is measurable. Subjective data is usually verbally given, okay? So blood pressure, yes, that is something, that is an assessment finding that we will need when administering medications. What's another objective finding? Yep, temp, oxygen, yep.
Pulse.
Pulse, yep. All of those things we were going to need. I'm sorry, somebody was going to say something.
I was going to say allergies.
Allergies, yep. Weight, absolutely.
Would like a bladder distension? I mean, distended abdomen.
Mm-hmm. So tell me when we would need to know, like, what would a distended bladder have to do with giving medications? You're not wrong, but I want to make sure you have the right thought process.
I mean, if they have a distended bladder, that's usually fluid overload, isn't it?
Not necessarily. So if somebody has a distended bladder, and we are giving medication for urine retention, we want to know. That is a way that we'll be able to tell if their medication is effective, right? That's how y'all are going to start applying the nursing process to giving medications. So if I'm giving a medication for bladder distension, and before I give it, their bladder is distended, and after I give it, and they have, you can palpate their bladder, and after I give it, they can't, then and you can't, was their medication effective or ineffective? Just based on that one finding. I kind of talked in circles, so y'all might not understand my question. Bladder was distended before we gave the medication. Bladder is not distended. Effective. That medication was effective. Okay. So yes. So bladder distension is not kind of one of those things that is always going to apply, Cindy, but it will sometimes apply, based on what you're giving. So let's see what's pupils. So yes, so medications can affect the way your pupils look, right? If a patient is on an opioid, they're going to have pinpoint pupils, or a stimulant, they're going to have pinpoint pupils. And that's something that we're going to assess. We're going to pay attention to that. Signs of inflammation, absolutely. So if we're given ibuprofen, we need to know if their medication is, is that inflammation improving? Those are things that we can do. Okay, so I saw somebody say, have you eaten or not? Is that objective or subjective?
Isn't that subjective?
Yes, so it would be subjective unless it was incredibly specific, like the amount of fluid intake, 240 milliliters. But if you just say, have you eaten? And they say, yeah, I ate a little bit of breakfast, and it's not measurable, then that would be subjective. Let's see. Let's see. Swelling, yes, because if we're given meds for swelling, we want to know what it is. When would a CBC matter? I see your question, so I'm going to go into it in a second. Caitlin B, why would we care about a CBC in regards to med administration?
If you're administering like a blood thinner or something for blood clotting.
Yep, we want to know what their platelets are, right? If we're administering something. What about if we are administering antibiotics? What part of that CBC are we looking at?
White blood cell count.
Yep. So Zoe, question of the year. Zoe wants to know, would pain be objective or subjective? The patient has to describe the pain, but it's technically measurable if you use a scale. So I would put that in both categories. I won't ever ask you if it's subjective or objective. Pain is always technically objective because it is what the patient says it is. Okay, our measurable tool there is really still what they're saying. We're not actually, like oxygen, they can't alter their oxygen. You see what I'm saying? Like they can't alter that. It is what it is. Their pain, they can say it's one thing and it's really another, but that's not for us to determine. So it could be classified as either. If you're using the 0-10, technically that's measurable. That would go under objective, and the subjective would be aching, burning, et cetera, et cetera. So it kind of goes both ways. You're welcome. Good question. All right, so we're pretty good about assessment, huh? Y'all seeing where all of this stuff that you learned in fundamentals is coming into pharmacology? All right, let's see. So, and this is basically going to be things that we already said, but I'm going to read them anyway. Objective and subjective data collected when the patient is first seen in the hospital, outpatient clinic, healthcare provider's office, or other type of healthcare facility. Objective data is obtained during the initial assessment through activities such as examining the skin, obtaining vital signs, palpating a lesion, auscultating the lungs. All of those things are measurable. Subjective data is acquired during initial assessment by obtaining information from the patient, such as family history, allergy history, occupational history, description of the current illness or chief complaint, medical history, or drug history. So all of that is kind of like your word data. It's no facts, it's no hardcore measurable type stuff. Any statements made by the patient about relief or non-relief of medications used in the past, basically what they say is subjective, what you can measure is objective. So each time, assessment is not a one-time thing, which I think y'all know that. You don't assess your patient and then say, oh, I did my head to toe, I'm good, we're good for the day. You assess your patient, and then you, all throughout the day, you do an ongoing assessment. Are you going head to toe every single time you go in the room? No, but are you noticing a difference, you know, in their pressure after you give them a blood pressure medication? That is an ongoing assessment. So in regards, let me not get ahead of myself. So ongoing assessment, we're not assessing one time. We've already talked about this. Blood pressure, respiratory rate, temp, weight, all of that is going to be objective. All right, so assessment, we all feel pretty good about assessment? And not just how to assess, but how it relates to our patient. Okay, so where do our nursing, I'm going back. Let's see if y'all listened to me last semester. Where do we get nursing diagnosis from?
Back of that foundations book.
Back of that foundations book. Yep, Nanda. Do we make them up in our little hearts? No. Are they medical diagnoses? No. We pull them from that approved list. So, do y'all have y'all's foundations book semi close by? I think I got one. All right, I'm gonna throw out. Y'all can open to if you have your foundations book, you can open it up. If you don't, I'm gonna read out some nursing diagnosis, and you tell me if they have anything in the world to do with pharmacology. Okay? If you don't have it, it's not a big deal. If you do have it and you get there before I do, tell me what page it's on.
It's on page 855.
Thank you, ma'am. All right. Let me give y'all a few seconds to look through that and find me two, if you have it, two diagnoses that have to do with given meds, with pharmacology.
What's the page again?
854, 855, and 856 in your green pharmacology book. Okay, so nobody has typed a wrong answer, but I want y'all to elaborate. Mackenzie, when would acute pain have anything to do with pharmacology?
When you're giving like Tylenol or like any pain medication.
Absolutely. Macy, yes, you're on the right track. That's the one that always stands out to me above anything else. It's not necessarily more right. Your patient can have deficient knowledge in every medication you're giving them. That's why we educate, okay? You have to, that is a diagnosis. That is pretty much a diagnosis for anybody getting a new medicine. I was prescribed a new medication yesterday, and I've been reading about it. I've heard of the med. I've seen the med before, but I want to know some information. I have deficient knowledge, and I teach the class. Let's see. Caitlin said risk for unstable blood glucose and acute pain. So, risk for unstable blood glucose. What would that specifically matter for in regards to given? Okay, I guess kind of answered itself, but what medications?
Yeah, insulin. I didn't know if you meant like before giving meds, or if you have that as your NANDA diagnosis, then you would administer.
So either way, that's why I wanted to talk it out. So most of your nursing diagnosis, with your diagnosis, a lot of your interventions are going to be to give medications, because that's what nurses do. So Abigail said anxiety. So yes. And diarrhea. So these are two, I'm actually glad you typed both of those. Those can also be medical diagnosis, okay? But they are on the NANDA approved list because it's something that we can observe. Do y'all understand that? So if I said PTSD, that is not a nursing diagnosis, but anxiety is on that list. We can observe their anxiety. We can observe their diarrhea. Therefore, we can say, yes, they're anxious. Yes, they have loose stool. So definitely. We all will hear a lot about my friend Jamie. She knows I use her in all of my lectures because she is hilarious, and I always call her Freak. She is like terrified of all meds. Like, so she'll call me and she'll say, Brittany, I took a Tylenol yesterday for a headache at 4 a.m. and I need to know if I can have another one. And it's like 10:30 at night. And I'm like, Jamie, you can have them every 4 hours. It's fine. She's like, but what if it's still in my system? Like, even if it's still in your system, it's going to be okay. You're going to, so, or she'll go to the doctor and she'll be like, he gave me this, but I just don't think I'm going to use it because I just read all the side effects and I'm not doing it. It's a risk of death, Brittany. Did you know that it is a risk of death with amoxicillin? I'm like, yes, if you have an anaphylactic reaction. Have you ever had an anaphylactic reaction? No, you were fine. But people have an incredible amount of anxiety surrounding medications, okay? It's not our job to say, I'm joking about Jamie. It's not our job to say, you're ridiculous. That's an unrealistic fear. It is our job to educate them, to give them all of the information that they need, and to calm their fears as best we can with our facts that we have to give them, okay? Risk for infection when we are giving our antibiotics, yep. And mood regulation, impaired mood regulation when we're given antidepressants, absolutely. All of those apply. So let's see. So ongoing assessment, we said that. Well, I must have went back because I already talked about that stuff. Okay, nursing diagnosis. So these things, our diagnosis provides a framework for selection of nursing interventions to achieve our expected outcomes. We talked about that they came from NANDA, from that list, the North American Nursing Diagnosis Association. These are, y'all have already pretty much given me a lot of them, but these are the frequently used nursing diagnoses specifically related to the administration of drugs. Anxiety, non-compliance, deficient knowledge, ineffective therapeutic regimen management. What does that mean? If their diagnosis is ineffective therapeutic regimen management, what might mean? I cannot talk. Let me start it.
They didn't take it like they were supposed to, like if they just took it and then stopped and they started to feel better or something?
Yes. So that could go under non-compliance. I would put that more under non-compliance if they didn't stick with their treatment. But ineffective therapeutic regimen management is their treatment regimen is not effective for what's going on with them. And exactly, Caitlin, we need to reevaluate their medications. We need to bring that to the physician's attention. So y'all weren't necessarily wrong, but that's more under non-compliance. If they are given the information and they're not taking it as prescribed, they're non-compliant. If they're given the medication and it is not effective, then we need to reevaluate those medications and those dosages. And if it's effective, we need to tell them to keep on taking it, right? So planning. The nurse develops expected outcomes after nursing diagnoses are formulated. So our goal is that we want our patient to obtain the maximum level of wellness that's reasonably attainable. So like in regards to given pain medications, is everybody's pain goal going to be a 0? Everybody's pain goal is not going to be a 0 because everybody has different needs. And a patient with chronic pain, the best they might ever get is a 3 out of 10, right? So we want our planning to be reasonable. We want our patients to effectively manage their regimen. We want them to understand their regimen, and we ultimately want them to comply with their regimen. Can we force a patient to take their medications?
No.
Nope. A patient has the right to refuse them, absolutely, positively. Can we encourage them?
Yes.
We can encourage them. We can tell them why they're taking it, why it's good for them, why it's prescribed, but we can't make them take it. People have the ability to make that choice. So your patients can absolutely refuse their medications. Let's see. In planning, the nurse is going to select the appropriate interventions. Going to describe the steps for carrying out the nursing activities that are specific and will meet expected outcomes. And those expected outcomes are going to serve as a basis for evaluating the effectiveness of nursing interventions. When we're implementing, we're going to actually carry out the plan of action. We're going to administer those specific drugs. So that is our implementation. So if our diagnosis was anxiety, we are going to administer Valium 10 milligrams Q4 hours as needed. That is our actual implementation. We want to take into consideration if our patient is willing to regulate and integrate into daily living the treatment regimen. So is it feasible for everyone to take medication 6 times a day? Do you feel like that's feasible? Yeah. Is it feasible for the person who is at home hanging out? I'm not saying hanging out. They live at home, they're home all day, and their responsibilities are in the home. It's going to be more reasonable for somebody that is in the home setting to do that. But we have to take those things into consideration because if it's not reasonable, they're not going to be compliant. And we need to know, is the patient willing and able to manage their treatment regimen? So if our patient is not able to administer injections to themselves because it totally freaks them out, should we have them self-administer their meds?
No.
If they're like, nope, can't do this, never will do this, not going to happen, we're not going to send them home on an injection that they're unwilling to give themselves, right? They're going to need to look at alternative methods. So this is basically everything we talked about. If their diagnosis is ineffective therapeutic regimen, we're going to discuss the drug regimen. We're going to tell them all about why it's going to be taken, what to expect. If their diagnosis is deficient knowledge, we're going to determine what information the patient is lacking and plan a teaching session that directly pertains to the area of need. We're going to just talk for 2 hours about all of the all of the stuff that they need to know if really their area of knowledge deficit is just knowing how to give the injection. We're going to hone in on what they need to know. And then your evaluation portion of the nursing process is we're going to see were those nursing interventions, were they effective or were they not? We want to see if the family and the people involved in our patient's care are understanding those interventions and the use of the medications. We're going to evaluate our patient's response to therapy. So we're going to have to follow up after giving medications. All right. Let's see, slide 17. All right, I think. Hold on, I'm trying to get where I can see y'all. Can y'all see me?
I just see you.
Bring a little box. Oh, now I see you.
Okay. All right. I think that's a good stopping point. I'm gonna talk to y'all for a few more seconds, and then I'll let y'all go at 2:30 since we didn't really have a real break. Everybody still feels good? Y'all all right? Questions, comments, confusions? Everybody's good. All right, let's see. Let me find y'all one question to ask.
This isn't related to today, but do you know anything about our clinical simulations that's taking place next week?
No, I don't. I'm sorry.
All right, thank you.
Miss Adam, have y'all been given a clinical instructor? Let me stop recording. Hold on. I hope, look, if I can't upload these recordings, y'all,